All right, let's jump right in. We're going to tackle one of the trickiest situations you can face in anesthesia, managing a patient with myasthenia gravis. And this isn't just about textbook knowledge. This is a real-world, high-stakes clinical scenario that, honestly, demands absolute precision, the latest tools, and a totally fresh way of thinking.
So just imagine for a second, you see it on the schedule for tomorrow. Myasthenia gravis. What's your first gut reaction? Oh, it's a routine case, or does your brain just instantly kick into high alert? Because let's be real, with these patients, every single decision we make, from the drugs we choose to how we reverse them, is like taking a step on a very, very narrow tightrope. So let's break down exactly why.
To even begin to navigate this, we have to get back to basics. We have to understand the battlefield itself, and that is the incredibly fragile and unpredictable neuromuscular junction in a patient with myasthenia.
So at its very core, myasthenia gravis is really a case of mistaken identity. It's an autoimmune disease where the body's own defense system, for some reason, goes completely rogue. It starts attacking and destroying these vital acetylcholine receptors. You know, the little landing pads for nerve signals that are supposed to tell our muscles to get to work and contract. And what I really like about this slide is how it breaks this whole process down. It happens in 3 steps. First, you've got these autoantibodies. You might see them labeled as anti-AChR or anti-MuSK, and they just swarm the motor end plate. Then, step 2, they just start destroying the receptors. The number of working receptors absolutely plummets. And the result? Well, the signal fails. There are just too few landing spots for the acetylcholine, so that message from the nerve to the muscle to contract, it just gets lost in translation. And that's what leads to that classic muscle weakness we see.
So what's the bottom line for us? This damaged junction creates this just wildly unpredictable environment. These patients can be hypersensitive to our normal muscle relaxants, but, and this is the weird part, they can actually be resistant to others. It's this profound unpredictability that makes our job so incredibly challenging.
And just when you think you've got a handle on it, a whole new landmine appears on the field. And that's the complication of GLP-1 agonists.
I mean, let's face it, these drugs, Ozempic, Wegovy, all the semaglutides, they're everywhere now. So the question we have to ask ourselves with pretty much every single patient, and especially a myasthenic patient, is what happens when their already fragile system has to deal with the pretty dramatic effects of a GLP-1 agonist? And this slide just lays out the problem perfectly. You take a standard MG patient, and you can pretty much count on predictable absorption of their absolutely crucial medications, like pyridostigmine. But you put that same patient on a drug like semaglutide, and 2 really dangerous things happen. First, their stomach emptying slows to a crawl. This makes the absorption of their MG meds totally erratic, which can destabilize their disease. And second, and this is the big one for us, they are now, by definition, a full stomach patient, which just sends their risk of aspiration through the roof.
This means we need a whole new playbook. If that patient is on a weekly GLP-1 and it wasn't stopped at least 7 days ago, you have to assume they have a high aspiration risk, period. Best practice? Grab an ultrasound and do a quick point-of-care gastric scan. If you see content in there, the game plan has to change. A rapid sequence induction using rocuronium with sugammadex ready for a full reversal isn't just a good idea, it's really the safest choice you can make.
But here's the good news. As the challenges have gotten more complex, so have our tools. We now have this incredible 21st century toolkit that lets us be incredibly precise, monitor things in real time, and reverse our drugs safely. I absolutely love this quote from the source material because it's just perfect. The Train of 4 monitor, it's no longer just some gadget to see if your muscle relaxant is working. No. In a myasthenic patient, think of it as the Holter monitor for their neuromuscular junction. It's giving you a live, real-time, quantitative window into the severity of their disease right there in that moment. A huge part of our job is to be the guardian of that fragile junction. And that means we have to know which drugs are basically poison to these patients. We're talking about certain antibiotics like aminoglycosides, really common hard meds like beta blockers, and most importantly, let me be crystal clear on this one, magnesium sulfate. Giving magnesium to a myasthenic patient is an absolute contraindication. It can cause a complete and total disaster.
Now here is a classic modern-day dilemma for you. Robotic surgery is amazing, but to be safe, it requires absolute, dead-still paralysis, not a single twitch.
But for an MG patient, even a teeny tiny dose of a muscle relaxant can cause a block that is dangerously deep and can last for hours and hours. So, how do you solve that puzzle?
Well, the solution is actually this really elegant two-step protocol. You don't avoid the relaxant, you master it. You use tiny microdoses of rocuronium, I'm talking like 10 to 20% of what you'd normally give, and you titrate it with painstaking care, guided by quantitative monitoring like post-tetanic count. And then, at the end of the case, you use the ultimate safety net, Sugamadex. It gives you a complete, totally predictable and safe reversal, and it honestly doesn't matter how deep that block is. Okay, this slide right here. This is the aha moment. In the old days, we used neostigmine. But giving neostigmine to a patient who's already taking a similar drug, like pyretostigmine, well, that's like pouring gasoline on a fire. You run a huge risk of pushing them into what's called a cholinergic crisis, which paradoxically causes even more weakness. But Sugamadex, it's a complete game changer. It doesn't even touch the neuromuscular junction. It just works in the plasma, floating around and grabbing onto rocuronium molecules like a little molecular Pac-Man.
So the key thing to understand is that Sugamadex is a selective agent. It was engineered to do one job and one job only, find and wrap up rocuronium. And what that means for us is we get a fast, complete, and incredibly reliable reversal, all without any of those dangerous side effects at the receptor level.
And that brings us to maybe the single most important number in this entire explainer. Before you even think about pulling that breathing tube, the train-of-4 ratio absolutely must be greater than 0.90. This is not a suggestion. It is a mandatory safety threshold, and it has to be confirmed by quantitative monitoring. No feelings, no guessing. Just the number. Zero exceptions.
So when you put all of these advances together, it has led to a completely revolutionary shift in how we think about recovery for these patients. The old rules, well, they just don't apply anymore.
The new prime directive is very simple. Spare the respiratory muscles at all costs. We cannot afford to weaken their diaphragm, even a little bit. And the foundation of this whole strategy begins with precision regional anesthesia. And this chart just says it all. Look at this. For shoulder surgery, the classic inner scalene block, the one we've all done for years, it paralyzes the phrenic nerve, and by extension, half the diaphragm, over 70% of the time. For a healthy patient, maybe okay. For an MG patient, that's totally unacceptable. But now look at the modern alternative, a superior trunk block. You get the same great pain relief, but the rate of phrenic nerve palsy plummets to less than 5%. That is the kind of precision that changes outcomes.
And you know, whenever it's possible, the absolute best, the gold standard technique, is one where we can avoid muscle relaxants completely. A total intravenous anesthetic, or TIVA, using something like propofol and remifentanil, lets us create excellent surgical conditions for a whole range of procedures without ever having to touch that fragile neuromuscular junction.
And all of this culminates in this really powerful, paradigm-shattering statement. The old belief, the dogma, that every single patient with myasthenia automatically gets a ticket to the ICU after surgery, that's just no longer true. That paradigm has fallen.
So who does still need the ICU? Well, now we have clear, evidence-based criteria to guide us. You're looking for patients with long-standing disease, say more than 6 years, people on really high doses of pyretostigmine, patients with poor lung function going in or a history of lung disease, and this last one is critical, anyone with pre-existing bulbar symptoms, meaning they already have trouble swallowing or speaking. Those are the patients we still need to earmark for that higher level of care.
So I'll just leave you with this question to think about. When you combine this deep understanding of the physiology with our modern tools like Sugamadex, like quantitative monitoring, and these new phrenic-sparing regional blocks, are we finally entering a new era? Are we turning that high-stakes tightrope walk into a much wider, much safer bridge for some of our most vulnerable patients? It sure feels like we are.